Okay, good evening all. Hope you all are doing well and safe too. Before we move ahead, I would like to request you all to just go through the disclaimer. This is a protocol from the organization that requesting all attendees that kindly do not take any pics or record the presentation. Okay. I hope my slide is visible.
Yeah, it is visible.
Yeah. Just giving you a brief regarding the webinar series, which is commencing from today, that is 17th of October. We would be catching up for the coming 5 weekends, that is 17th October to 14th November. We would catch up by 7 p.m. to 8:30 p.m. And these are the topics which has been mentioned, that is from 17th, 24th and 31st of October and 7th and 14th of November. These are the 5 weekends which catch up and the topic mentioned. Okay, so requesting all to be well in time as today. I would like to invite and welcome Dr. Raja Selvaraj. I am, for sure everyone would know him, cardiac electrophysiologist heading the Department of Cardiology in JICMA, having a vast experience in CID implantation, follow-up and troubleshooting, EP study, RFA procedures and mapping. Around 120 publications in various books and chapters. He's also associate editor in Indian Pacing and Electrophysiology Journal, a reviewer of many national and international journals, and a renowned personality all across. And a fantastic photographer. I've come across, I've seen a couple of his pics which he has uploaded. Today's session, that is pacemaker indication and patient selection for pacemaker implantation, will be taken by Dr. Raja Selvaraj. Just giving some ground rules, setting up some ground rules for the 90 minutes which we have been blocked in. The conference operator will mute your line. Speaker will be happy to take your questions. Please post them in the chat box. Towards the end of the session, speaker will try to answer your questions as much as possible. And as mentioned in the previous slide, we would surely catch up the next weekend too for the next topic. That is 24th of October, same time, 7 p.m. to 8:30 p.m. And the topic would be basic technical concepts, pacing and sensing. Along with Dr. Raja Selvaraj, we would have a Medtronic trainer. By this, I would hand over to Dr. Raja Selvaraj. Over to you, sir.
Thank you, Roshan.
Yeah.
So let me just share my screen. Okay, so good evening, everyone. This training program for the young trainees has been like an annual tradition from the Medtronic side, and for as long as I know, for young electrophysiologists training in India, this program for device therapy and BARD's program for electrophysiology used to be the sort of rites of passage that we used to go through, and with time, of course, things have changed, and this time this is in an online format, which has some disadvantages, of course, but has a lot of advantages also in that it allows the opportunity for a lot more people to attend with a lot more ease, and also allows us to spread the topics over 5 weekends. So this week, to start off the program, I'm going to talk on pacing indication and mostly about the indications for pacing and a little bit about mode selection. And I'll be keeping the topic fairly basic, trying to stick to the essential points, not get into too much details, because that is something that you can always read up. And I think we'll finish fairly ahead of time, so we'll have enough time for some discussion also. So the key references that I'm going to follow in this, and which you can read up later if you want to, sort of the Bible as far as pacing indications goes, is the 98 guidelines from the American Heart Association and American College of Cardiology. And obviously, it's more than 20 years since that was published, and but because the indications for pacing as such have not changed much, the updates have later only addressed indications for CRT and ICDs. But for indication for pacing as such has not changed much, and this remains, like I said, the keystone on which we base all our indications still. There was a 2018 guideline on the evaluation and management of patients with bradycardia, which to some extent covers this, but really doesn't change much of the indications. So you can look into that also. And then there is an ESC guidelines from 2013. But like I said, most of the what I'm going to cover in this talk is going to be based on the 98 guidelines. So broadly, when you think of indications for pacing, we are going to pace patients who have significant bradycardia, a slow heart rate, or if they don't have bradycardia, they have conduction abnormalities which indicate a risk of future bradycardia. And that is the first essential thing that has to be there before you think of pacing somebody. And you either need to have symptoms, or in a patient who is not symptomatic, the reason for pacing can be to prevent a possible risk of death in the future. So one of these has to be there. And usually these things have to be reversible. If bradycardia, even if it is symptomatic, is due to a reversible cause, then again, it does not need to be paced. So some irreversible cause of bradycardia or a future risk of developing bradycardia, which is either causing symptoms or is associated with the risk of death. So this is very broadly when you would consider pacing a patient. To come to the specific guidelines, I'll primarily discuss about guidelines for indications for pacing, and the two main categories for which we pace patients are sinus bradycardia and AV block. To some extent, the split up between the two will vary between institutes, but mostly it is like a 50-50 split up, or can go to about 30-70 like us, so it varies a little bit. But these two form the primary indications of pacing, and 95% of patients who undergo a pacemaker implant fall into one of these categories. So these are the two things into which I would go into a lot of detail. We'll start off with sinus bradycardia. So in the guidelines, if you see class 1 indication for pacing in a patient with sinus bradycardia has both of them have the term symptomatic in them. So very important to this, I'll keep on emphasizing here that sinus bradycardia is something where you consider pacing only when symptomatic. So again, I say this because we repeatedly get referrals or people asking about somebody who is asymptomatic and an ECG showed a heart rate of 50, 45, whatever. As long as they're asymptomatic, usually you do not consider pacing. Symptoms is the most important reason why you need to consider pacing in sinus bradycardia. And the reason is that sinus bradycardia does not kill people. So sinus bradycardia does not result in increased mortality, unlike AV block, which can result in mortality. So the only reason you can then pace in sinus bradycardia is to alleviate symptoms. So that is why you're much more conservative when pacing patients for sinus bradycardia, and you're very specific about looking for symptoms. Now, symptomatic bradycardia makes sense. Patients have have syncope or pre-syncope, and they have resting bradycardia. But there's another category here called symptomatic chronotropic incompetence, which what this means is that a patient may not have symptoms at rest, but has symptoms on effort. So the patient may say that they're not able to do an activity which involves some effort. So they climb a flight of stairs or try to run fast. They become breathless. They're unable to do. They have a feeling of fatigue when they take up some effort. And in these patients, you can establish that there is chronotropic incompetence by exercising them. And we have some various formulae to identify what is a age-adjusted expected maximum heart rate, like the simple formula, like a 220 minus heart rate. And if you find that they do not achieve, say, 75% of that, you can assume that there is significant chronotropic incompetence, and if you especially see that you reproduce the symptoms and the reproduction of symptoms is associated with an inability to elevate their heart rate with exercise, this can be an indication. But I would say this is a sort of soft indication, and personally, I haven't treated many patients for chronotropic incompetence. And if you see the ESC guidelines, they again caution against using this very broadly. So it's a very small subset of patients who would really qualify for the term chronotropic incompetence causing symptoms. So the most important class 1 indication for sinus bradycardia is symptomatic bradycardia. So this I already covered. It's very, very important that symptoms are there. Asymptomatic bradycardia never need to treat. So people are worried that resting heart rates are 45. Sometimes they put a Holter on, and then while asleep, their heart rate falls to 35, and they're worried about that. As long as it is asymptomatic, never consider treating them. And sort of the converse is true. If patients have symptoms and you've established that symptoms are not related to bradycardia, again, that tells you that you do not need to pace patients. So what I mean is, like, if you have a patient with paroxysmal episodic pre-syncope, and while you see them in the OPD, if they say, I'm feeling giddy right now, this is the same symptoms I have. And if their heart rate at that point is, say, 60 beats a minute, 60, is not going to cause giddiness, then you know that their symptoms are not related to the slow heart rate, and therefore they do not need to be paced. If you have some symptoms and you have some bradycardia, now again, that is not enough. So a patient might say intermittently he has giddiness, and you record an ECG showing a heart rate of 55, they have some amount of sinus node dysfunction. But you have not correlated the bradycardia with symptoms. Correlation is important to make it a class 1 indication. The way you would correlate is if you put on a Holter and the patient tells you that he had the symptoms reproduced at 4:30 p.m. and you see that at 4:30 p.m. the heart rate fell to below 40 and you're sure that caused the symptoms, then you have correlation. So when you have correlation, it's a class 1 indication. The other important thing with sinus node dysfunction is to rule out other causes. So again, it's a condition that can be seen as a secondary phenomenon in a lot of conditions, and you have to be sure that it's a primary sinus bradycardia, it's a primary disease of the sinus. So physiologic bradycardia can be seen in athletes, but you can also have a lot of disease states where you can have bradycardia. Most important would be drug therapy. So patients might be already on beta blockers, and if you don't check that, so if you see that, then, and if the drug is not essential, you can stop it. Rarely there may be an indication where there may be a situation where the drug cannot be stopped. Patient may be, say, have disease, coronary artery disease, which cannot be revascularized and requires a significant dose of beta blockers to control his angina. And if you think you cannot stop the drug, patient has significant bradycardia, you might consider pacing. Or again, a patient might have significant bradycardia and have long QT syndrome, needs a very high dose of beta blocker, then again, you might need to pace. So essential drug therapy is fine, but non-essential drug therapy, if it is causing the bradycardia, then consider stopping the drugs. And of course, hypothyroidism, usually clinically evident, but if you have a suspicion, always rule that out before pacing these patients. It's never an urgent condition to pace. Always be alert of patients with sinus bradycardia who come as an acute presentation. They're symptomatic since 2 days, come with syncope, require temporary. Often there is a secondary cause. There are systemic issues. So look out for those, because typical primary sinus node disease presents as a chronic disease, rarely comes as an acute, severely sick patient. Now, I said that to have a class 1 indication, you need to have association of the bradycardia with symptoms. You should be able to associate the two temporarily. But very often, most of the patients where we pace, we are unable to establish this clear association. So in that case, you can still pace them as a class 2A indication when you have symptoms and you have sinus bradycardia with rates reaching less than 40, but your association is not clear. So patient says episodic symptoms, and either on a resting ECG or on a monitor or a Holter, you can see that the rate drops below 40, but patient doesn't tell you clearly that is the time when he had symptoms. So you can assume that it's most likely caused by that and pace them. So this is a 2A indication. I'll show you later. Actually, ESC has downgraded this to a 2B indication. Again, tells you that these are conditions where you don't have to be that rigid about pacing. It is fine to even wait some time and try to establish association if you want to be sure that the patient will benefit from pacing. When you pace like this, you will find that about 50% of the patients finally come with no benefit. They say that I still continue to have the same symptoms. And sort of coming to 2B or 3 indications, asymptomatic bradycardia almost never have to pace. So if you have asymptomatic bradycardia, but the heart rate while awake is less than 30, it's given as a 2B indication, meaning sometimes you might consider, but generally again, it's something that is discouraged. And if you have symptoms clearly documented, not related to the bradycardia, it's a class 3 indication, do not pace. Now, just note this term awake heart rate. So this is again something important. I'll keep coming back to this later also. I'll discuss this when we discuss about Holters. So a lot of these patients with sinus bradycardia end up getting a Holter because their outpatient ECG shows a heart rate of 50. They have some vague symptoms. So you put on a Holter. Now, the first thing that people report on the Holter then is their minimum heart rate and the longest pause. So I think that's a wrong way to interpret the Holter. The first thing to see when you see a Holter is, did the patient have symptoms? So patient had symptoms or did not have symptoms? If patient had symptoms, report the time when the patient had symptoms and report the rhythm at the time of the symptoms. So if you say that the patient had symptoms lasting about 15 minutes starting at 5 p.m. and this was associated with a drop in his resting heart rate to 35 beats per minute, that is a clear class 1 indication. So this is what you should look for in a Holter. The other second point, what I was telling you, don't blindly only look at the minimum heart rate on Holter. So you can go by patient diary, ask the patient when the patient slept, or even if you look at the heart rate profile, you usually can identify when the patient is asleep and when patient is awake. So usually report minimum awake heart rate, average awake heart rate separately from the sleep rates. Sleep rates have very less importance. I would say they do not have any importance. So this also happens when patients get admitted in a hospital and are connected on a monitor. During sleep, rates tend to drop normally, both in patients with AV block and sinus bradycardia. And that is again, especially in sinus bradycardia, that does not carry any import. Whereas if an awake rate is slow, then that can carry some importance. And the last point is pauses are not important. In sinus bradycardia, they do not carry any importance. So a pause more than 2 seconds or 2.5 seconds or 3 seconds by itself is not an indication to pace. This is the ESC guidelines, a very sort of summarized view of this and a very sensible, logical way of looking at things. So class 1, that is you pace when patient has symptoms clearly attributed to the bradycardia. So you have symptoms, you have bradycardia, and you have a clear relationship between symptoms and bradycardia. It's a class 1 indication. When you have symptoms, patients, you have bradycardia, symptoms are likely to be due to bradycardia, but evidence is not conclusive. Like I told you, the AHA guidelines, it's a 2A, ESC says that's a 2B indication. So very clearly, this is not a very strong indication to pace. Discuss with the patient, see if you can spend some more time to clarify the relationship between the symptoms and the rhythm, and definitely no hurry to pace this subset of patients. And clearly class 3 is patients who are asymptomatic. So asymptomatic here, there's no threshold of heart rate also. Asymptomatic do not need to pace. So that is about sinus bradycardia. Now we'll come to AV block. Now again, when it comes to heart block, my suggestion is always to use clear-cut terms as 3rd degree AV block, 2nd degree AV block, 1st degree AV block, and 2nd degree either type 1 or type 2 AV block. So the term that people often tend to use as high-grade AV block doesn't carry significance, is used differently by different people. I would suggest not to use that. So I'm going to use these terms. So we'll first discuss what are the indications in 3rd degree AV block. 3rd degree AV block obviously is AV block where there is absolutely no relation between atrial activity and ventricular activity. So the class 1 indication, you can divide as patients with symptoms and without symptoms. So if you have 3rd degree or complete heart block with symptoms, then you don't need to look at anything else. Doesn't matter. The level of block doesn't matter. The rate, escape rate, or the width of the QRS, nothing matters. Once they have symptoms and they have complete heart block, you have to pace them. So that's very clear. And most of the patients with 3rd degree AV block will fall into this category. But there is a subset of complete heart block patients, I would say probably about 10 to 20%, who would be asymptomatic. Now, some of these are not truly asymptomatic, they're minimally symptomatic. So especially the elderly might present with very mild symptoms. They may not have obvious syncope. They may have a little bit of easy fatigability, reduced effort tolerance. And sometimes if this is chronic, they become adapted to it so that they don't have obvious symptoms. So in that group, if you can elicit that there is really symptoms, and some of these people just improve once you pace them. But there is a small subset of patients who absolutely do not have symptoms. When you don't have symptoms, the indications to pace would be, one is based on the awake heart rate. So if your awake heart rate is less than 40, it's still a class 1 indication to pace. Now here, a pause is again considered important. Now here, pause and rate are important, unlike sinus bradycardia, even in the absence of symptoms, because significantly a long pause or a slow heart rate suggests that your escape focus may not be very reliable. And in that case, there is a risk of brady-induced tachyarrhythmias or significant bradycardia itself, leading to either syncope or death. So there is an indication to pace these patients. Now, another important category is iatrogenic AV block. So if your AV block happens after a surgery or AV block that is after ablation, either intentionally created or happens by accident, all these patients have to be paced irrespective of symptoms, irrespective of the level of block or the rate of the escape rhythm. So always pace these patients. And one other in place where you would pace patients irrespective of symptoms is neuromuscular disease. So again, not very common. We see it once in a while, but myotonic dystrophy or any of the neuromuscular conditions where there is AV block, these patients are known to be at a high risk of progression, high risk of having malignant outcomes from this AV block. So it's generally considered better to just pace them. For asymptomatic patients, like we discussed previously, if their awake heart rate is less than 40, it's a class 1 indication to pace. If they have an awake rate more than 40, but they are clearly acquired complete heart block, they're asymptomatic, still can go ahead and pace them. It's a 2A indication. Now, what happens with second degree AV block? Now, second degree AV block, now there are a couple of important things here is to try and distinguish type 1 from type 2 AV block. So you know the ECGs, I'll show you some of the ECGs also. Type 1 AV block is the classic Wenke-Back rhythm, where you can see that consecutively conducted beats have a progressive prolongation of the PR interval, followed by block for one P wave, and then it resumes conduction from the next beat onwards. Whereas a second degree type 2 typically has no change in the PR interval among the conducted beats. That's one of the things. Now, when you have 2:1 conduction, by definition, there are no two consecutive conducted P waves, so you cannot assess for a Wenke-Back kind of PR prolongation. So in that case, it's better to just call it 2:1 AV block, and there we make a presumptive diagnosis from the ECG as to whether it is a type 1 or type 2 based on two things: the width of the escape QRS and the PR interval of the conducted P waves. Now, a typical nodal block or a suprahesian block has a narrow QRS and a long PR of the conducted interval, while an infranodal block typically has a wide QRS and a shorter conducted PR interval. But ECG can be erroneous, and if you do an EP study, electrophysiology study, you can make a more correct diagnosis. So I'll be showing examples of ECG and EP tracings. So I'll show this. Now, again, here symptoms rule. So second degree AV block, if patient has symptomatic bradycardia, irrespective of the level, patient needs to be paced. So for example, if it is clearly a narrow QRS rhythm and it's a suprahesian, it's a nodal block, but still if the patient's rate is 40 and patient is fatigued from it, then obviously you need to go and pace these patients. So that's a class 1 indication. If you have asymptomatic second degree AV block, in that case, it becomes important to know whether it is infranodal or nodal. So if you see a type 2 pattern on the ECG, it's considered typically infranodal. Or if you demonstrate on EPS that it's intra or infrahesian block, then you need to pace these patients. So clearly nodal block has a more benign prognosis, can be physiological or functional, whereas infranodal block typically indicates pathology and has more malignant outcomes. Therefore, this differentiation. Now, how do you identify on the ECG? Like I was discussing, so here this is a patient with 2:1 block for the as his dominant rhythm. So most of the time, like if you take the last 4 beats here, you can see clearly a non-conducted P wave and then a conducted P wave. But here, if you see the QRS is narrow, PR is not very long, but the typical pattern in a nodal block is also that the PR would be a little longer, like 200 or more. But PR is probably about 180 milliseconds here, and you have a narrow QRS. But here you have another clue that for one cycle, you have a change from 2:1 to 3:2 conduction. And when it changes to a 3:2 conduction, we can clearly see that the PR interval prolongs on the second conducted P wave. So all these findings tell us clearly this is a nodal block. So in this patient, if patient has symptoms due to this bradycardia, you have to pace this patient. But if this patient is asymptomatic, there is no risk of increased mortality because of this rhythm. There is no risk of this rhythm progressing to complete heart block. Therefore, you do not need to pace. Again, you have this patient where now different from the previous ECG, you can see here there is a white QRS, there's a left bundle morphology, and you can see the consecutive conducted PR intervals, you can see all remain constant. So there's a block P wave, and you can see there are 3 conducted P waves here, 2 conducted P waves here. All of these are conducted with the same PR interval. So this tells us this is a second degree type 2 AV block. So a short PR, no change in PR, and a wide QRS escape. So this typically, even if this patient is asymptomatic, this is a patient who is likely to progress to complete heart block, likely to have a more malignant disease, and therefore should be paced. And so what can happen is, if on EP study, how we establish is we place a catheter in the his bundle region, which usually records atrial activity, his activity, and ventricular activity. So the electrograms, you get electrograms of atrium, his, and the ventricle. And when we do this here, so you don't need to know a lot of EP, most of you may not be familiar, but just to tell you what we look for, we have the ECG where we see a P wave conducted to the QRS. Here you have a P wave not conducted to QRS. Here again, we have a P wave and it's conducted to the QRS. So the question here is, did this block in the node that is above the his or below the his? So because we are recording a his electrogram, if you see a his electrogram and then block, that means it blocks below the level of the his. Whereas if you do not see a his electrogram, it blocks above the level of the his. So that's as simple as it can be. But there is this rare condition of an intra-Hisian block. So here if you see relatively narrow QRS and a longer conducted PR, both of these suggest that the block is in the node, and you would have thought it's a benign prognosis. But this patient had syncope, had some documented intermittent complete heart block, and on EPS what we find is that there is disease of the his bundle, so that the his conduction itself is prolonged. There are 2 his potentials, and the block happens after a first his potential. So after the A, we see 1 his potential, and then we do not see a second his potential, implying that block is happening within the his Purkinje system. And this is a rare condition known as intra-Hisian AV block. Again, needs to be paced. Now, so we discussed third degree AV block and second degree AV block. Is there any indication to pace first degree AV block? Usually no. 99% of patients with a first degree AV block do not need to be paced. A rare indication to pace is what is called as a pseudo pacemaker syndrome, or when you have symptoms of pacemaker syndrome. So the indication as per the AHA is if you have symptoms of pacemaker syndrome in association with a first degree AV block with alleviation with temporary pacing. So what does this mean? So pacemaker syndrome is a condition where you have, so this is one of our patients actually from a few years back, and looks very bizarre, this ECG, but what actually it is this is sinus tachycardia. This is the P wave, and this whole thing is the PR interval, and there's the QRS, and you can see the next P wave comes almost right on the QRS. So pacemaker syndrome obviously is a condition that you see in patients with a pacemaker where you're pacing the ventricle and there is intact VA conduction, so that the A happens right after the V. And what happens when the atrial systole happens right after the QRS is that the atrium contracts against a closed tricuspid valve. It's usually not able to open the AV valves, and therefore all the rise in pressure inside the atrium is transmitted back into the veins, into the jugular vein, activates the baroreceptor, results in fluid retention and all the other symptoms. So finally, patients develop symptoms of heart failure. So here, even though patient does not have a pacemaker, because the patient has such a long PR interval, the RP interval becomes short, so the patients develop symptoms of a pacemaker-like syndrome. So this also becomes a sort of vicious cycle, because once patients develop symptoms because of this, they develop sinus tachycardia. And when they have sinus tachycardia, the RP interval gets shorter and shorter, because with sinus tachycardia, now the PR interval occupies a larger part of the cycle length. RP interval becomes shorter and worsens there. So this was a middle-aged lady who came with this heart failure, and LV was not dilated. EF looked normal, but this was the ECG. And if you see the guidelines, to just remind you again, it says alleviation with temporary pacing. So I'll show you what we did for this patient. I don't know this. So unfortunately, this image has not come here. Okay. So what actually happened is this patient had clearly pulses alternance and a reduced systolic pressure. And when we put a temporary dual chamber pacemaker in this patient, and we paced her, we found that with the pacing the atrium and ventricle with the physiologic AV delay, we were able to abolish this pulses alternance. So then we went ahead and implanted a permanent pacemaker, and with that, the patient's heart failure resolved and patient improved. Now, after first degree AV block, we have the conditions of bundle branch block and fascicular blocks, and what are the indications to pace in this. So a little bit about the terminology. We think of here, we are basically describing the cardiac conduction system as consisting of three fascicles, and the three fascicles would be the right bundle, the left anterior fascicle, and the left posterior fascicle. So typically when you have a right bundle branch block with either a left anterior or a posterior fascicular block, which will manifest respectively as a left axis or a right axis deviation, then you call it as a bifascicular block. Now, if you have one of these, right bundle with an axis deviation, with in addition a prolongation of the PR interval, then we assume that the third fascicle is also diseased, and therefore we call it as a trifascicular block. If you have a right bundle branch block with a prolonged PR interval without any axis deviation, you can still think of it as a disease involving both the left anterior and posterior fascicles, producing an equal delay in the two, so that you don't get a net axis deviation, but the PR is prolonged, and you can still call that trifascicular block. But a more accurate term or a different term to use in that condition is a bilateral bundle branch block, but you will usually treat it similar to trifascicular block. Same goes for a patient with left bundle branch block and a prolonged PR interval. Again, it indicates that left bundle is blocked and the right bundle is also diseased, so you can call it as a bilateral bundle branch block. But as far as indications goes, you'll consider it equivalent to trifascicular block. So in these patients, so it's a very typical setting where patients with trifascicular block or bifascicular block come with syncope. Now, the first thing is to look for other causes of syncope. If you exclude other causes of syncope, you're reasonably certain there are no other causes, you can take it as a class 2A indication to pace. If patient does not have syncope, you incidentally find bifascicular or trifascicular block, usually it's enough to wait and watch. It is not necessary to do an EP study for these patients. But supposing you have done an EP study for some other reason, and if you find that the HV interval is more than 100 milliseconds, it is considered an indication to pace. And finally, if you do an EP study, the HV interval is not more than 100 milliseconds, but you can demonstrate infrahisian block happening during pacing, and which is not functional, not physiological, then again it's an indication to pace. So now this last point is something I want to elaborate a little on, because again that can be very tricky. Now, by itself, infrahisian block seeing during an EP study is not uncommon, and it's very difficult, or at least let's say not easy to distinguish a physiologic infrahisian block from a pathologic infrahisian block. So demonstrate with an example here. So this is a patient, we're doing an EP study. What we do is atrial pacing. We've placed, these are 2 beats of atrial pacing, and this is an atrial extra stimulus. So during the atrial extra stimulus, like I told you, the His bundle electrogram records an A, His, and a V. And here you see A, His, and then no V. So this is a block happening below the His. Now, when this happens, so this is infrahisian block, but this is not an indication to pace. So very important to understand that a property of the His-Purkinje system is being very exquisitely sensitive to the preceding RR interval. So the HH interval here is long. So after this long HH interval, the refractory period of the His, because of this long interval, will be again long. So when the next H comes in much earlier compared to this previous HH, it tends to block as a physiologic phenomenon itself. This is not an indication to pace. So when we consider it pathologic HV block is when it happens without abrupt change in cycle length. So if you just pace at a rate of say 70 beats per minute, go up gradually to 75, go up to 80, go up to 85, go up to 90. And at some point during this, if you see infra-ACN block, then it can be considered an indication to pace. So don't be very aggressive in pacing patients for pacing-induced infra-ACN block unless you are sure that it is physiologic. Another condition that comes up commonly is post-MI AV block. Now, the indication to pace a patient in post-MI AV block is persistent symptomatic AV block, whether it's second or third degree. So very clear, symptomatic and persistent. Now, the term persistent is less clear. So what it means is that after an MI, some patients can have transient AV block. So that is not an indication to pace. Persistent means we have assumed that this is not transient anymore and this is not going to revert. Now, the question is, when do you do this? The guidelines don't clearly put a time interval, but classically accepted is at least 7 days. You can push it to 10 days or 2 weeks if you want, but usually when AV block doesn't resolve or doesn't show any signs of resolution by 7 days, it can be considered to be persistent. So if it's persistent, complete heart block, or persistent symptomatic second degree AV block, you can pace them. Now, if they are asymptomatic and you have second degree AV block, then you have to see whether they are infranodal. Now, typically, AV block in some of the inferior wall MIs is very clearly nodal. You can see a Wenckebach kind of block, you can see a narrow QRS, so there you would not need to pace them. Whereas if it is infranodal, then you need to pace. If you have transient AV block in a patient after an MI and it resolves, if you have complete resolution, that means you have a narrow QRS with a normal PR interval, you do not need to pace them. But if there is a residual bundle branch block, it is considered an indication to pace. Even though their AV block is resolved and they have 1:1 conduction, if they have a residual bundle branch block, it is an indication to pace because they have a high risk of developing AV block again. So as far as the AV block is concerned, these are the ESC guidelines. Second or third degree AV block, third degree AV block or second degree type 2 AV block, class 1 indication, you have to pace. So if it is complete heart block, always pace. Second degree AV block, if it's below the node, always pace. If it is type 1, if it causes symptoms, or even though it looks type 1 on the ECG, but EPS shows it's intra or infra-His, 2A indication to pace. Whereas the only place which is type 3, AV block, it's fine to even pace when they're asymptomatic because it's always as a borderline, so it can still be considered a class 2 indication. So the only place where AV block is an absolute no-no to pace is reversible causes. In practice, reversible AV block is typically either seen with high-dose beta blockers, if they're on drugs, if they're on beta blockers, or sometimes they're on a combination of beta blockers with digoxin or beta blockers with calcium channel blockers, and then you can stop the drugs and wait and see. Sometimes patients with renal failure with hyperkalemia may present with AV block, which resolves after correction of the electrolyte abnormalities. And the other common place which can sometimes be mistaken is acute MIs. So an acute inferior wall MI and patient develops AV block. If the MI is not very clearly evident, that might be mistaken. So if you identify that it is MI, again, it's a reversible cause, so you wait for resolution. A few other conditions. One is to discuss about reflex syncope. So generally, we have a fairly high threshold for pacing and reflex syncope. So a lot of trials and interest is there because it's a large subset of patients. A lot of patients have troubling symptoms due to reflex syncope, but a lot of reflex syncope is benign. So even though these patients have distressing symptoms, have repeated falls, parents are worried because their children are fainting at school and all this, but typically they have a benign outcome. So the threshold for pacing should be very high in these patients. Now, carotid sinus hypersensitivity is something which is the only one which has class 1 indication, and it is class 1 when there is a reproducible syncope. So this is typically as the textbook description of somebody who has a tight collar, or when they are shaving, or when they turn their neck suddenly to one side, something that causes pressure on the carotids and they have syncope. And then you're able to reproduce this by doing a carotid sinus massage, which produces a very prolonged asystole or significant bradycardia and the symptoms. So if this happens, it's a class 1 indication. Again, beware that a lot of elderly patients can have a hypersensitive response, that if you put pressure on their carotids, they can have asystole. But if this does not reproduce their symptoms exactly, if you're not sure that the symptoms are related to this, but patient still has syncope, so you want to be, you don't want to take a chance, you want to pace them, it can still be, you can do that, and that's a class 2A indication. Now, if you leave out carotid sinus syncope and come to the usual vasovagal syncope, or what is called a neurocardiogenic syncope, it's a 2B indication by guidelines still. And only when you have a heart reproducing symptoms with it showing to be a typical cardio-inhibitory type, where the sinus bradycardia and not hypotension is the dominant cause of the syncope. In that case, pacing might help these patients. And typically in these cases, you have to pace with a dual chamber pacemaker, ideally with a device which has a rate drop response. Now, the ESC guidelines are even more conservative when it comes to this. And so again, don't be misled by a lot of the trials and newer technologies which promise a lot of results in this. So very nice summary in the ESC guidelines, which says that in patients with reflex syncope, pacing should be the last choice, should only be given to highly selected patients. This is typically relatively old age with severe forms of reflex syncope, with history of recurrent syncope and frequent injuries. So it's typically an old person who has recurrent syncope, has injuries during the syncope. And the injuries, so most of the patients with reflex syncope, especially the younger patients you will see, will never have injuries because they have some amount of prodrome. So prodrome always acts as a warning. They start feeling giddy, so they go and sit somewhere, and so they don't have severe symptoms. But sometimes the elderly may have lack of prodromal symptoms, and so they end up with injuries. In these patients, you can consider pacing. And also a very relevant point here, the fact that pacing is effective in some patients does not mean that it is necessary. So you could put a pacemaker and say the syncope frequency has come down or syncope severity is mitigated. That doesn't mean that you have to pace these patients, because so anyway, a patient who has, say, 2 episodes of vasovagal syncope in a year and doesn't have injury from that, what is the need to pace them? You're not changing outcomes in any way. So always be very, think of clinically meaningful outcomes and discuss with the patient before considering a pacemaker in these patients. Congenital heart block is a tricky question when it comes up. It's people vary in their approaches to this. Some people are very conservative, not because you'll see a lot of patients even at the age of 40 coming with a narrow QRS rate of 60 with heart block, which they have lived to an age of 40 or 50 with this. You have to think whether you need to pace them. And on the other hand, you might have a newborn or an infant with a rate of 50, and then again you have to consider whether you have to pace them or not. So it's always a tricky thing. When you have symptoms, clearly it's a class 1 indication. So this tends to happen. Sometimes you have these 10, 12-year-olds who have a syncope and they have congenital heart block. They have a rate of 50. So there's no question, once they have symptoms, you have to pace them. If they don't have symptoms, we typically evaluate for cardiomegaly on X-ray or reduced ejection fraction on echo, or a wide QRS escape on the ECG. So any of these would be an indication to consider pacing in these patients. Purely rate-based cutoffs should always be taken as a sort of soft measure. So even though some rate cutoffs are given, you don't have to absolutely strictly adhere to these. You can look at the overall picture. But the general rate cutoffs given in an infant, 50 or 55 with a normal heart, and less than 70 in the presence of congenital heart disease. So like I said, this is still something that you have to individualize, because very often you might see a newborn or a 1-month-old with a rate of around 50 or a little less than 50. And there because taking a decision to pace those patients is a huge decision, because it usually means a thoracotomy, placement of an epicardial lead, an abdominal pulse generator, and over a lifetime, this patient is going to require multiple lead revisions, multiple device revisions. So think about it, and especially in the newborn period, sometimes their heart rate tends to be low, but it picks up quickly over the next few days. So if they're developing well, they don't have symptoms, have a narrow QRS, it's always fine to, I think, wait and just monitor them more frequently and watch out. Once they cross infancy, rate less than 50 is generally considered a class 2A indication. One sort of interesting condition is children who come with long QT syndrome with AV block. Again, typically seen in infancy. It's typically a very malignant long QT syndrome, which has a very prolonged QT. And because the QT is, of course, the repolarization, which is a refractory part of the ventricle, the QT is so prolonged that PVF cannot conduct. You get functional AV block. So these children usually need to be paced. So this was an ECG which was shared to me by a pediatric cardiologist just about a month back of a child that he had seen. And you can see here, it's a noisy ECG, but let's say you look at V4, you can see very clearly there is bradycardia first for a newborn. And you can see a P wave here, which is conducted, a P wave here, which is not conducted. There is 2:1 block. Look at the QT interval. The QT uncorrected here is about 800 milliseconds. So, and very clearly you can see the P wave is here. You obviously cannot get a QRS here, right? Because the T wave is there. So, here, this is a functional 2:1 block because of a very prolonged QT interval. So my advice on what was done in this patient was to put a pacemaker, an epicardial pacemaker, and treat the child with beta blockers. Now, that covers most of the indications. We covered sinus bradycardia, complete heart block, and a few miscellaneous conditions, including reflex syncope, congenital heart block, post-MIV block. And now, very briefly, I'll discuss a little bit about mode selection, because once you decide that you want to put a pacemaker, the next decision is what pacemaker to use. Now, for sinus bradycardia, so this mostly I'm following the 2018 guidelines for recommendations, but I'm going to tell you more of personal experience and what we practice. If you look at the evidence, very clearly, atrial-based pacing. Now, this is a term that you would understand. Atrial-based pacing means either single-chamber atrial or a dual-chamber pacemaker, which has atrial pacing capability, should always be recommended over single-chamber ventricular pacing. This is a class 1 indication. So the trials are very clear on this, and evidence is very, very strong that in sinus bradycardia, BVI is very bad. So I would go as far as to say that probably patients paced with a single chamber ventricular pacemaker do worse than those who are not even paced. So even though there's no trial data on that, I would say that they do worse. So please do not pace VVI in patients with sinus bradycardia. So as we saw a spate of this happen a few years back, when the government insurance schemes were introduced and insurance was available only for single chamber pacemakers. So a lot of physicians were comfortable with single chamber ventricular pacing only. And so a lot of patients with sinus bradycardia who for years had gone on with their sinus bradycardia with only mild symptoms and doing fairly well. Now, because a pacemaker, and financially they did not afford a pacemaker. Now, because a pacemaker was available to them free on the scheme, they underwent implantation of a single chamber pacemaker. And I have seen 2 or 3 patients come now with atrial fibrillation, recurrent strokes, bad effort tolerance, symptoms of heart failure. So they tend to do very badly. Very clearly, once you start pacing these patients VVI, because the patients with sinus bradycardia already have an enhanced propensity to stroke and atrial fibrillation. Once you pace them VVI, you accelerate them on this course. So something that you should clearly not do. When it comes to dual chamber versus single chamber atrial pacing, if your patient cannot afford a dual chamber pacemaker, always put a single chamber atrial, do not put a single chamber ventricular. Now, if they can afford a dual chamber pacemaker, which one should you choose? If you have any AV conduction abnormalities, obviously, so if there's bundle branch block or a prolonged PR interval, definitely choose a dual chamber pacemaker. If either of these are not present, then choosing any of these, either a dual chamber or single chamber atrial pacing, is fine. Both of these come under class 1 indication. The usual practice and recommendation in the West is to prefer dual chamber over single chamber. There were a lot of early trials which did not really show a benefit for either of these coming from the Danish trials. But there was a Dan-based trial which suggested a dual chamber might be better in terms of less occurrence of AF. But really, this reduced occurrence of AF was limited to a subset of patients with a PR more than 220 milliseconds at baseline. So again, if you have patients with sinus bradycardia, you're going to take them up for pacing. Two things I look at are their QRS width and their PR intervals if they have some conducted P waves. If you see that their PR interval is normal and their QRS width is normal, it is fine to pace them single chamber. Many people practice looking at their Wenckebach block cycle length during implantation. We do it sometimes, but really there's no evidence to suggest that that has any value. And even if your block cycle length, so usually the Wenckebach block happens within the node. So it's really a marker of autonomic tone at that point, and where block happens in the node, it's not really going to predict future AV block. So going strictly by evidence, that should not carry any value. Now, if you program dual chamber pacing, definitely try to minimize ventricular pacing. So previously, the only way to do this was to prolong a very long PR interval, or you have to put them in a AI mode so that later, in case they develop AV block, you can put them, then you have to reprogram them to a DDD mode. But now all devices have good algorithms to reduce pacing. So from AV hysteresis to manage ventricular pacing, various algorithms. So use one of these to minimize ventricular pacing. In patients with AV block, so obviously there is no role for AI pacing. So here usually the decision to make is between VVI, VDD, and DDD pacing. Now, generally DDD pacing is dual chamber pacing is preferred over VVI pacing because it seems intuitive that you're giving them maybe synchrony, and that should result in improvements in their effort tolerance and functional class. But sort of surprising when you look at the evidence that there's absolutely no, or let's say there's no good, strong evidence that DDD provides better functional outcomes compared to VVI pacing in these patients. So especially in patients who have comorbidities, patient is not very ambulant, not mobile, old patient, or for example, in a patient with trifascicular block or bifascicular block, who has intermittent AV block and is not really going to be paced most of the time, VVI pacing is very reasonable. Even in a patient with persistent AV block, if they cannot afford a dual chamber pacemaker, or there are other reasons where you want to avoid putting a dual chamber pacemaker, VVI pacing is very much reasonable. But if you can, I think DDD is fine. Now again, between dual chamber and VDD, VDD is an option which is used less and less now, but definitely it's an option to consider. Now VDD, the main advantage is so that you can do VDD with 2 leads, and you can use a VDD pulse generator, which can save you some costs. So if a patient has a good sinus rate, then you don't really require atrial pacing. Atrial sensing is adequate. You can use a VDD pulse generator. But now there's usually not much cost difference, or you do not get separate dedicated VDD pulse generators. In that case, the other option is to use a single coil VDD lead. Now that provides an advantage over a DDD lead because it's a single pass lead, in that you don't need to get 2 axes and put 2 leads. You can just put 1 lead and get VDD pacing. But the problem with a single pass VDD lead is a proportion of patients develop loss of atrial sensing. But this, I would say, is about 10% in the long term. If you're ready to accept that if that happens, the patient is going to go into VVI pacing, that is still an option to consider. Now, in patients with AV block, at least, especially in the current scenario, you have to be alert to the possibility of patients developing a pacemaker-induced tachycardia, pacemaker-induced cardiomyopathy. So what this means is that RV apical pacing especially, but any pacing, even alternate locations in the right ventricle, can result in the development of heart failure or reduced ejection fraction in some patients. One of the strongest predictors is resting ejection fraction. So if you clearly have a reduced EF, if it is clearly less than 40% or 35%, there's no question at all, definitely give them physiologic pacing, means either a cardiac resynchronization therapy or probably his bundle pacing, no. But even if their heart function is mildly reduced, it's not normal, so EF is less than 50%. If the patient is expected to have almost 100% pacing, that is, patient is in persistent AV block, definitely consider pacing with more physiologic activation. This is a class 2A indication. And lastly, this, okay. Now, when it comes to rate response. So the other thing when you decide to put a dual chamber pacemaker or a single chamber pacemaker is, should you take an SSI device or should you take an SSIR device? Or when it comes to DDD, should you take a DDD or a DDDR device? Now, whatever trials have been done of DDD versus DDDR have not really shown a huge benefit of adding rate response to DDD. So I would say the main place where you can consider a DDDR is if you're going to use a dual chamber pacemaker in a patient with sinus bradycardia who has chronotropic incompetence. So the patient typically has resting sinus rates of 40, and with effort also rate doesn't go up to beyond say 50 or 60. So you want them to pace in the atrium and their atrial pacing rate to go higher when they exercise, then definitely give them a DDDR pacemaker if you're not putting a single chamber device. If you're putting single chamber devices, like you're putting AAI for sinus node disease or VVI for CHP, definitely prefer a rate responsive device over non-rate responsive device. So especially if you put a VVI for CHP, clearly VVI-R has been shown to be superior to VVI in terms of effort tolerance. And actually, when you look at the DDD versus VVI trials, DDD is superior to VVI in heart block, but DDD has not been shown to be superior to VVI-R. So adding rate response in the ventricle for patients with complete heart block definitely is a big improvement. So always consider rate response when you put it in the ventricle. So to summarize the key take-home points, sinus node dysfunction, whenever you think of pacing, the main question you should ask yourself is patient symptomatic? So unless they are symptomatic, do not pace patients with sinus bradycardia. In AV block, two things you're asking yourself: is patient symptomatic? If patient is not symptomatic, what you should be asking yourself is the level of block. Level of block below node, yes, you can still pace if they are asymptomatic also. And when it comes to mode of pacing, in sinus node dysfunction, definitely do not pace VVI. That should be a key message. Do not pace single chamber ventricle in patients with sinus node dysfunction. DDD is definitely superior, and DDD may be slightly superior to AAI. In AV block patients, DDD or VVI-R, DDD may be slightly better than VVI-R, but they're almost equally effective, so you can take one of those. And again, to just tell you the references, which you can refer again when you have specific doubts when it comes to individual patients: 98 guidelines from the ACCHA, the 2018 guidelines from the ACHA, and finally there is the ESC guidelines just published recently. So with that, I'm going to stop there, and I think there were a few questions. We'll look at that.
Can I read it out, sir?
I can see the questions here. So
Okay.
So one, Abhishek has asked, can hypothyroidism lead to AV block? Not typical. Typically, it results in sinus bradycardia. I don't know. I guess if it is a very severe malignant hypothyroidism, you could get significant depression of AV conduction also, but not very typical. Typical is sinus bradycardia. Then Sudhanshu has asked, patient post-anterior LMI revascularized as QRBBB with a normal PR interval with ventricular rate of 80. Do we need to pace? No, just a QRBBB happening after anterior LMI is not uncommon. You know that with a very proximal LED involvement, once the septal is involved, you can get a right bundle branch block. By itself, it is not an indication to pace. So if you come by guidelines, the indication to pace would be if you had this patient had transient AV block. So patient had AV block resolved, and patients has RBBB, then definitely consider pacing. Or if patient has RBBB has a prolonged PR interval, then in that case, treat it as a bifascicular block. And there, if patient either has symptoms after this, or if you know that the patient's HU interval is prolonged, then you consider pacing. But this particular scenario that you say QRBBB normal PR interval, definitely do not need to pace. Then Sudhanshu again is a patient coming to OPD with episode of syncope 10 days back. PR interval of LBBB with a PR of 240 milliseconds. Now, that's a very good question. So this is a very common scenario, and I didn't really discuss this too much because I wasn't really discussing evaluation of patients with syncope. So like I said, first is what do you label this patient? So sometimes because of the different kind of terminology that is there, I suggest that you always call these patients by exactly what you see. I would call this patient as LBBB with a prolonged PR interval. But in terms of terminology, you can call this sometimes as bilateral bundle branch block. You can call this as a trifascicular block also, because a left bundle branch block implies block of left anterior and posterior fascicles, and a prolonged PR interval in this setting implies disease of the right bundle also. So you're going to essentially take it like a trifascicular block. So now patient had a history of syncope. So like I said before, one is you have to look for other causes of syncope. So if suppose that syncope happened when the patient was having when he's having an IV cannula put in, had pain and had syncope. So very clearly setting a suggestive of vasovagal syncope. And if you put them on a tilt table and you reproduce the same syncope with hypotension, then if it's a very clearly due to some other cause, may not be an indication to pace. Now, more commonly, you are not able to clearly find a cause of the syncope. So you have unexplained syncope and you have a bilateral bundle branch block or trifascicular block. So what do you do in these patients? One approach is to measure the HV interval. So when you measure a HV interval, if you do an EP study, measure a HV interval, and if you find that the HV interval is more than 100 milliseconds, then you can go ahead and pace these patients. And previously, guidelines also used to say that you do a VT induction for these patients. And because when they have left bundle branch block, prolonged PR interval, it tells us there is diffuse infra-SCN disease, and that these patients also may have malignant ventricular arrhythmia. So if they have an inducible arrhythmia, you may have to also consider implantation of an defibrillator. Now, again, what can happen in these patients is if you do a HV interval measurement, it may be only 80 milliseconds. Then you're left with the question of what to do. Now, one approach there is to give procainamide. That was like a way to stress the conduction system. And with procainamide, if you get a HV prolongation, that would be an indication to pace. That is done less commonly. We don't do the procainamide challenge. So then you have this subset of patients where you have unexplained syncope, you have LBBB with prolonged PR interval, and a HV interval which is not beyond 100. So what do you do? So there has been studies done on this where they implanted a loop recorder in these patients, so which is a good strategy too. You can implant a loop recorder, and if you implant a loop recorder, what you find in these patients is most of them, when they come back with syncope, and when they come back with syncope, most of them the cause is heart block. So what I would do and what I discuss with patients is two options. You either can directly go ahead and pace these patients, because you know that once they have LBBB, a PR of 240, and they have had syncope, very likely this is going to be intermittent heart block, just safer to pace them. Or you want to be a little conservative, you want to be a little academic, you're ready to accept another episode of syncope. You and the patient are ready to accept another episode of syncope to make a more correct diagnosis and avoid a pacemaker implantation if it can be avoided. Then an option is to do a ILR implantation. So ILR is very good in this setting. You implant an ILR 3-4 months back. If the patient has an episode of syncope, you can now go back and see what the syncope was due to. If clearly syncope happened, but there was no AV block, it's some other reason, you can evaluate for that. Whereas if AV block happened, you can pace them. So that would be the way I would look at this. So what are the indications for pacing in tachybrady syndrome? So tachybrady syndrome, the indications for pacing would be same as brady. So basically means that you have bradycardia, which is symptomatic. Now, the only things which come with associated tachyarrhythmias is that when there is associated tachyarrhythmia, sometimes the threshold to pace may be a little lower. So in the sense that you're a little more keen to pace them, because to treat the tachyarrhythmias, you may have to put them on drugs. So that is one reason. So some of these patients have recurrent paroxysmal atrial fibrillation and they're symptomatic with the tachyarrhythmias. You want to put them on some beta blocker or calcium channel blocker, but they already have a resting sinus bradycardia of 50. So in that case, it's fine to pace them in the atrium and then put them on drugs. And the other issue is that the tachyarrhythmias tend to worsen the bradyarrhythmias. So a lot of these patients, if they have some syncope, or sometimes they even give a very clear history that they get a fast heartbeat, they get palpitations stops, and they have syncope at the time. And then you put a Holter, and you'll classically see on Holter they have short episodes of atrial fibrillation, and when the atrial fibrillation stops, they can have asystole lasting 8 seconds, 10 seconds, and that is causes the symptom. So patient with tachybrady syndrome tends to get a pacemaker more easily, more often compared to somebody with an isolated bradycardia. Digoxin hyperkalemia leads to CHB. Yes, it does tend to result in AV block. So if you see AV block in that setting, you would usually wait. So typically you see this, this in patients with atrial fibrillation. Patients are put on digoxin for rate control, and suddenly they come with a rate of 50 with a regularization of the rhythm. Typical digoxin toxicity, and that is because of AV block, and they may have an enhanced junctional rhythm. And usually, in this case, you would ideally treat and typically it's worsened with hypokalemia, and you can treat the electrolyte abnormalities, stop the digoxin, and wait and see what happens before deciding to pace. Okay, patient has come with CHB, congenital CHB, heart rate of 87, needs to have major surgery. So this is again a very common thing that we also encounter. Now, a patient with heart block who may not have a direct indication to pace, because like we discussed before, we discussed some indications to pace in asymptomatic heart block. Awake rate is less than 40, or they have a white QRS, so some indication to pace. Like you say here, heart rate is more than 40, patient is totally asymptomatic, heart function is normal, so you don't necessarily want to pace the patient, but patient needs to undergo cholecystectomy. So here, usually you can take a decision in discussion with the anesthetist. Most of the time what happens is they prefer to have some pacing support during surgery, so we put in a temporary pacemaker on the day of surgery, and you can remove it the same day after surgery. And so your decision to permanent pace them need not be decided by the need to undergo surgery. So they undergo surgery with the temporary pacing, and your decision regarding PPA is done as usual based on guidelines and discussion with the patient. So this, I think we already discussed, bundle branch block with an increased PR interval by itself is not an indication to pace. If you have syncope with documented intermittent CHP, definitely indication to pace. If you have syncope with no other cause established for the syncope, then strongly consider pacing, but also consider ILR implantation or an EP study. That would be the answer. Patient with beta blockers presents with symptomatic CHP, should we pace him or wait for beta blocker action? So again, it's a little individual decision. Sometimes patient is on, let's say, carvedilol 3.125 mg, and patient has come with heart block. Very likely it's probably not related, and then you may decide not to wait. Or suppose the patient already has some heart failure, or patient has post-term LV dysfunction, and you feel the beta blocker is essential for the patient to improve their survival, then you can go ahead and pace them. But if clearly patient is on 200 mg of metoprolol per day, comes with heart block, it's always better to wait for about 5 half-lives. So wait 2 days, 3 days, and reevaluate. If patient has a residual bundle branch block or residual bifascicular, trifascicular block, I would still go ahead and pace them. But if they have complete resolution with a narrow QRS on a normal PR interval, and the beta blocker was not an essential drug, it was given for hypertension, and you have replaced it with another drug, then you don't need to pace them. So sinus node dysfunction patients always use GDD, but if patient has AF, then it is said that VVAR is better. What's the reason? Now, so AF and sinus node dysfunction. Now, if you have to decide whether AF is persistent AF or not. So that is the first question. So is it paroxysmal AF or persistent AF? Now, if it is persistent AF, that is, patient had sinus node dysfunction in the past, but patient has been in AF for the last year. You might even have tried a trial of cardioversion, and patient just did not cardiovert or reverted to AF. So you know the term persistent, long-standing persistent or permanent AF is a condition where you have attempted to restore sinus rhythm, and you and the patient together have decided that you're not going to anymore try to restore rhythm, and you're going to accept a long-term rhythm of atrial fibrillation. So in that case, when atrium is fibrillation, atrium is not going to be paced. So then there is no question of pacing the atrium. There is definitely no need for an atrial lead. And in that case, if patient still needs pacing because patient has a slow ventricular rate, then you have to give a VVAR device. Now, the other group of patients are patients with sinus node dysfunction who have intermittent AF, so the paroxysmal AF. So sometimes people are worried about dual chamber, thinking that you might have inappropriate tracking and fast ventricular rates. It's usually not an issue. You can always program around it. All the devices have mode switch on, so you can switch to a non-tracking mode with the set rate threshold. So that is not a reason to be worried about dual chamber pacemaker. And like I said, if patients have paroxysmal AF, if you put them on VVI, you're more likely to push them into permanent AF. So it's always better to pace them in an atrial-based pacing, which means either give them AAI or DED. And I think atrial pacing might have some amount of antiarrhythmic effect in that it delays their progression to permanent AF. So the answer is sinus node dysfunction with paroxysmal AF, definitely prefer DDD. But if it is permanent AF and they need pacing, then VVIR. Post-ACS thrombolysis, can we call it as persistent? So the mode of revascularization, or even whether revascularization was done or not, is not the determinant of whether it's persistent or not persistent. It is only based on time. So any AV block happening in the setting of an acute MI should be considered reversible unless a period of about 7 days has elapsed. So even if you do revascularization or you don't do revascularization, that doesn't matter. But if 1 week has elapsed after the MI and AV block is still permanent, is still present, then you can consider it as persistent. So congenital heart block with a narrow QRS escape. So like we said, in congenital heart block, patient has symptoms, you have to pace. So even if the patient has narrow QRS but has symptoms, then you have to pace. Other than that, like we discussed, obviously wide QRS would have been an indication to pace, but if they have, most of the congenital heart blocks have a narrow QRS. There, the indications to pace would be development of cardiomegaly, development of a dilated LV and reduced ejection fraction, even if they are asymptomatic, and a low escape rate. So typically, once they've crossed infancy, if the rate is less than 50, then you'd consider pacing these patients. So by guidelines, that is the indication to pace. Again, some people are a little more aggressive and consider that all complete congenital heart block should be paced because it's a very small risk of sudden death in these patients. But generally, if the escape rate is very good, more than 60, you do not need to do that. Let's say 50 to 60 is like a gray zone. Less than 50, you would pace. I think this we already answered, so that is done. I think most of these, yeah. So 30-year-old female coming with second degree type 2 AV block, do we need to rule out infiltrative cardiomyopathy? So again, it's a very important and interesting question. So always in your mind, don't only label the level of block, try to think what is the etiology. So if you see AV block, always think, is this congenital, is this acquired? And if it is acquired, is this typical degenerative or is this non-degenerative? So if you have a 30-year-old identified with AV block, if you see a narrow QRS and a rate of 60, and you ask the patients and they say, yes, at age of 15, I had an ECG or I was told that I have a slow heart rate, all that fits in, it is definitely congenital complete heart block, that is fine. Whereas if you have a 70-year-old or 65-year-old coming with heart block, wide QRS, a recent onset of symptoms, that is clearly degenerative acquired AV block. But if you have a 30-year-old block, a 30-year-old female, where clearly it is not congenital, it's a wide QRS, it's a rate doesn't fit in with congenital, or there's a previously documented ECG, instead of blindly pacing them, like you say here, you have to consider some form of acquired AV block, which is not degenerative. In that case, it is important to try and evaluate for causes, and one of the most important causes which can be missed is infiltrative cardiomyopathies. So what typically happens with these patients, again, we've had a few patients like this, is they get implanted with a pacemaker at that point because it's just diagnosed as any other AV block. But about a year down the line, they tend to develop progressive worsening of heart function, and then they develop ventricular arrhythmias, and they finally come to you with ventricular arrhythmias, LV dysfunction, and at that time when you evaluate, you find that they have infiltrative cardiomyopathy. So the guideline says that in a patient with AV block, if you identify that there is a granulomatous heart disease, you upfront give them a ICD instead of just putting a pacemaker. So that is one reason to identify this, and the other reason to identify this is that at an early stage, treatment might still result in some amount of reversibility if there is already LV dysfunction, or at least prevention of progression of LV dysfunction, prevention of development of scarring and LV dysfunction. So definitely in a setting like this where there's a suspicion of granulomatous heart disease, you should evaluate them for granulomatous heart disease. So that is very true. Most of them with cardiac sarcoidosis do not have systemic symptoms. So even in the absence of that, you should evaluate. It's a very good question here. DCM, severe LV dysfunction, CHB underwent BVI, persistent severe LV dysfunction, any point in recommending CRT. So the first question is, what should you do at first contact with a patient like this? So if a patient comes with a dilated LV and LV dysfunction who has complete heart block, so when you can clearly see there is LV dilatation and you're sure it's not due to an acute transient cause, upfront you have to treat them with physiologic pacing. So CRT, or in current scenario, probably his bundle pacing. So the setting you have said is that they initially got a VVI pacemaker for whatever reasons, and now they have, obviously, mostly what happens with this is either they are unchanged or they worsen. And when they come with that symptoms, definitely you have to consider upgrading them to a physiologic pacing. So definitely consider putting in an atrial lead and his bundle lead, or an atrial lead and an LV lead, and changing them over to CRT. So what is the importance of duration of pause? Like I was saying, it does not have an importance. Somehow this fixation is there on duration of pause. The Holter reports, automated reports, tend to give you the pause, and people immediately say there's a 2.5 second pause and need a pace. So you look at the guidelines, there's no indication to pace in sinus bradycardia based on the duration of pause. So it's like because a pause per se doesn't mean anything. You can, if you're most of the time your rate is 50, but one beat you have a pause lasting 2 seconds, 3 seconds, it's not going to cause symptoms. It's not going to cause any other syncope or death. So pause per se does not need treatment. That's what I would say. Becker syndrome, heart failure, no syncope, EF 25%, LHB, RBVB, prolonged PR interval, QR is 130 milliseconds, HV of 110, ICD, hot CRT, CRTD. Okay, so it's a complicated question. So basically what you're saying is there's a myopathy and patient has a reduced ejection fraction with heart failure. Now, and has a trifascicular block, right? So now, if we assume that we need to pace this patient anyway, because in patients with this kind of myopathy, once they have conduction system abnormalities, even if they have not progressed to heart block, it is always better to pace them. Now, if patient already has LV dysfunction, so automatically you want to pace them with CRT or with other forms of physiologic pacing, like what is meant as hot here is his optimized or left bundle optimized. So the newer methods of his bundle or left bundle pacing. So definitely that should be the choice. Now the additional complicated question here is whether you should implant an ICD also. I would probably say no. There's no strong evidence on this. Definitely physiologic pacing, because otherwise they're going to do worse. Probably implantation of a defibrillator would have to be taken in consultation with patients. Definitely something to consider, because with the LV dysfunction, they are probably at small risk of sudden death. But considering there is a systemic disease with anyway a poor overall long-term prognosis and the additional comorbidities of implanting a defibrillator, it's a decision that has to be taken in discussion with the patient. I think so. I would say discuss with the patient, but definitely either a CRTP or a CRTD in this patient. PPI-induced LV dysfunction, how to prevent this? Now, so prevention, like I said, so the main high-risk group is patients with reduced ejection fraction at baseline. So if patients, anybody with heart block, you're going to put in a pacemaker, already their EF is 45, always consider a CRT directly. CRT, or when I say CRT, I think in the current era, automatically consider his bundle, left bundle pacing as synonyms. So consider that instead of putting simply a VVI or TDD pacemaker. So that is the best mode of prevention. So like I said, the only high-risk group that we can think of is patients with a reduced ejection fraction at baseline. Patients with a normal ejection fraction at baseline can also develop some of them can develop LV dysfunction or heart failure. Now, there's no strong evidence on what is the best way to prevent this. What we tend to do is try to pace them in a more septal location. Evidence is not very strong, but generally it results in a narrower QRS. There's some evidence that the incidence of LV dysfunction might be less. Again, it makes sense that placing them in the his bundle region might reduce the risk of LV dysfunction. Again, evidence is accumulating only now. There are some trials ongoing whether every patient undergoing a PPI should have pacing in his bundle region. Right now, I would say there's no strong evidence, and there are some downsides of his bundle pacing, like higher thresholds and high risk of lead dislodgement and all this. So right now, I would not recommend that, but that is something that could change in the future. So we still have about 10 minutes or so. So I'll answer these next few questions. Can hyperglycemia cause CHB? Not that I'm aware of. I don't see physiologically why per se hyperglycemia would cause CHB. I'd say no. So some mention dysfunction with pause more than 6 seconds. So I think in the there's a guideline where if while awake, if there is a very prolonged pause, more than 4 seconds or something, it's considered like a 2A, 2B indication to pace. But like ESC guidelines and all clearly says that rate or pause doesn't matter at all. Unless it is symptomatic, it's not an indication to pace. So these are soft cutoffs, because normally you would not see somebody without significant bradycardia or symptoms to develop a 6-second pause while awake. So if you see the 6-second pause, it might be during sleep. And so if you really have somebody who is asymptomatic, I would say unlikely that they would have a 6-second pause. They have a 6-second pause, of course, you have to consider, knowing that it's like a 2A, 2B indication. But I would strongly think that is not a very practical scenario. Non-apical RV lead, yes. Now we almost never pace patients in the RV apex. So we almost always place an active fixation lead, and we place this in the outflow or the mid-septal region of the RV. Typically, it produces narrower QRS, better ventricular synchrony, and hopefully better long-term outcomes. But like I said, the evidence is not strong. And like I said, the interesting question that people are trying to answer now is whether to directly pace all these patients in a his bundle region. I would say at present, we should not do that, but long-term, that is something that might change. Finally, when to choose his bundle versus left bundle pacing, I think that's a very broad question, and that's out of scope of this, but I just very briefly answer that. If you decide to go for conduction system pacing, currently the two options are his bundle pacing or left bundle pacing. Now, in terms of hardware, it's the same hardware for both. So it's the same lead, same sheath. So usually it's something that you can even go back and forth. You can start with his bundle. If you don't get, you can just go to the left bundle region. Or you can, if you go with the left bundle, you can come back to the his bundle. So it's not a choice that you have to make upfront. Having said that, his bundle pacing has more evidence now in terms of number of cases done, number of years that it has been done, and all that is more evidence, whereas left bundle pacing is newer. His bundle pacing, I would say, is less invasive than left bundle pacing, which involves putting a lead deep into the septum, where we are still not fully aware of all the long-term risks that can happen. We already know of some small risks of perforating into the LV endocardially, producing thromboembolic complications from there, producing injury to the branches of the septal branches of the coronary arteries and things like that. And definitely seems to have a slightly higher risk of dislodgement. But left bundle pacing seems to have better thresholds, better R wave sensing, and probably a little easier to implant compared to his bundle pacing, which tends to have problems with a little higher threshold, and about 10% of patients develop a increased threshold over time. So right now, the pros and cons of each balance each other. So at this point, I would say both of them sort of balance out. It's an individual preference. You will see some operators who always go with his bundle first, some go with left bundle first. But again, you should be ready to switch. So at this point, I would say there's not enough to choose between either. You should know the pros and cons of each. And in individual patients, you have to decide based on the feasibility and the presence and site of bundle branch block in them and all that. So I think we're sort of almost at the end of time also, and we had a lot of questions, so that's good. That indicates a lot of participation. So I'll ask Roshan to close with whatever remarks here.
Yeah. Thank you, sir. And first of all, it was an excellent session, sir. And I'm sure that we have covered 24 questions, sir, and just right on time, that too. And I am confident that most of the queries have been clarified too, sir. Thank you all once again, and you will surely catch up next weekend too. That is on 24th of October, same time, 7 p.m. to 8:30. And have a safe weekend ahead. Thank you.
Thank you, Roshan, and thank you, everyone.
Thank you.
Thanks, doctor.